Well, thank you very much for the invitation to speak to you this morning. I'm a surgical oncologist and I'm a translational researcher at the Ottawa Hospital. This means that I spend about half my time operating on patients to remove their cancer, and the other half of the time trying to get promising discoveries from the laboratory to the clinic. So some days I'm in the lab discussing experiments and results with my team and the other scientists. And some days I'm seeing patients in the clinic and sometimes even enrolling them in clinical trials to get new therapies into the clinic. Some days I'm in the operating room and other days I'm trying to do all three. And it's pretty busy. And sometimes it's exhausting and often it's overwhelming. Many of my colleagues and my friends, and especially my family, ask me why I do cancer research. Trading sleep for grant and manuscript writing, trading clinical earnings for unpaid bench work, poring over rejection letters from cash-strapped funding agencies instead of thank you letters from grateful patients. I usually tell them that it's exciting to be part of a team to find new research discoveries and uncover new knowledge, and it requires a different skill set, which is challenging, and it is definitely so rewarding when these fundings are published and recognized, especially if they can impact my cancer patients. And most important, cancer research gives hope to my patients. And all of this is true. But none of it is the real reason why I persevere and why I can never give up. I wrote this one cold February morning, and I think it will explain why. It is real, it is very personal, and some might find it graphic, but it is my truth. It's called Hope for Tuesday. It's Tuesday. No one else is awake, and the quiet stillness is a rare privilege at home. In the soft morning light, I see the silhouette of two of my sons, piled like puppies in the middle of our king. My husband deserted his side hours ago in our nightly dance of musical beds. I tiptoe carefully down the stairs. If even one of my children wakes up, then I will never make it to work on time. With a steaming coffee in hand, I breathe out white air into the cold February morning and head to the hospital. Tuesday is my OR day. I have a big case today, a locally advanced rectal cancer. The patient is younger than I am, with children younger than my own. While still not common, the incidence is increasing in this under 50 age group. We're going to do a pelvic exenteration. That means we'll remove all of the organs in her pelvis, including her rectum, anus, uterus, cervix, vagina, and bladder. She will have a bag on the left called a colostomy for stool, and a bag on the right called a urinary conduit for urine. We will take muscle and skin from both of her inner thighs to reconstruct her vagina. I remember her face when I first told her, confusion and disbelief. "You can live like that? How?" She said. "Yes, you can. It will be different," I reply, as if that wasn't obvious. By the time she finished her 3 months of preoperative therapy, that disbelief had turned to quiet resignation. It's the price tag for life. The alternative is worse. Today, she has a determined look, ready to face the surgery and its aftermath, and ready to be cancer-free. But I can tell from her grip on my hand that breathtaking fear is not far below the surface. Before she drifts off to sleep, she whispers, "I'm gonna be okay, right?" She looks directly into my eyes. The problem with the OR is that with a mask and a hat, you only have the eyes to look at. You can only see the eyes. And without the support of the rest of the face, the eyes cannot lie. I reply without hesitation, "There is no doubt in my mind that you will be better than okay. You go to sleep and let me do what I'm trained to do. Next time we see each other, it will all be over and the cancer will be gone." "How can you be so sure?" asks the surgical resident later. "Because I have to be." Positioning, tucking, taping, prepping, draping, and the surgery begins. The tumor is enormous, filling the entire bony pelvis, and there's almost no room to maneuver around it, like trying to extract an egg from an egg cup without breaking the shell. With the gentle whirring of the air vents, the smoke evacuator, mixed with the beeping of the cardiac monitor and the high-pitched tone of the cautery knife, we do a dance of too close, too far. If we're too close to the tumor, then we risk leaving tumor behind and certain recurrence. But if we're too far, we may injure the nerves and blood vessels in the pelvic sidewall, risking a life-threatening bleed or paralysis. The temperature of the room is above average to keep the patient warm during these long cases, but that, combined with the bright lights on our heads and the waterproof gowns, create an experience akin to Bikram yoga. My biceps and forearms fasciculate with fatigue, and I feel beads of sweat running down between my shoulder blades. By late afternoon, my colleagues from urology and gynecology have joined me, and they remain at the abdominal incision while I proceed to the bottom to remove the anus and the vagina. We use a hot knife to help cauterize the blood vessels and reduce the bleeding, but regardless, this is the bloodiest part of the operation. My eyes burn from the smoke, and I'm only vaguely aware that my socks are soaked as blood drips into my shoes. What I'm acutely aware of is how barbaric this is, cutting out pieces of flesh along with human dignity. This can't be the only way. Finally, the tumor is removed. The margins look good and the bleeding has stopped. Now for the long process of reconstruction. When we're finally done, I look at the clock. It's almost midnight. With dinner, homework, and bedtime long over, I creep quietly into my house. I'm starving but exhausted. I trade food for a shower because my hair smells like smoke and my toes are still sticky. I push a small, warm, pajama-clad body to the middle of the bed. Relocation is futile, and I collapse. Another Tuesday behind me. A famous surgical oncologist, Blake Cady, once wrote of cancer, "Biology is king, patient selection is queen, and surgery is the pauper who sometimes tries but rarely succeeds in usurping the throne." There is nothing like Tuesday to remind me that I am just a pauper, indentured and powerless against the biology of this sinister disease. I cut out the tissue, and when the biology allows it, patients are cured. I'm not sure how many more Tuesdays I can do this, but I truly believe that by the end of my career, I will be doing something completely different on Tuesday, a much better way of treating cancer. Being part of a translational cancer research team, seeing clinical trials make scientific advances become miracles for first a few patients, and then many more. That gives me hope to persevere. I do cancer research because it's the only way I can get through Tuesday. Today, I'm asking you to have hope for Tuesday too. Thank you.